So you are 2 hours into your shift,
Okay.
and suddenly you hear the bed alarm blaring from room 4.
Oh, that sound. It instantly spikes your heart rate.
It really does.
Yeah.
You rush in, and you find a patient who, was resting quietly all morning, but now they are completely frantic.
Yeah, attempting to climb over the bed rails, pulling at their IV lines.
Exactly. And they are looking at you like you are just this terrifying stranger. So in that split second, standing in the doorway, you have to decide something huge.
Right. Is this the natural progression of their baseline cognitive decline, or is this a brand new life-threatening emergency?
And that moment, that is the ultimate test of clinical judgment for a newer nurse. Welcome to an episode of the Super Nurse Podcast, created by Brooke Wallace.
And just to mention, Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author. She has navigated that exact bedside chaos more times than she can even count.
Now, to be completely clear right up front, neither of us are Brooke Wallace. But this entire conversation is built directly from her bedside knowledge, her clinical notes, and her signature teaching style.
Yeah, we are here to help nursing students and new nurses actually apply what they know in real patient care, bridging that gap between the textbook and the bedside.
Before we get into the heavy physiology today, please take a quick second to subscribe and watch the video version of the show on YouTube. The link is in the description. Just look for our channel. It's called Super Nurse AI.
So our mission today is to translate complex neurological concepts into plain English.
Because you need to know exactly what clues to look for at the bedside, why they matter, and, how they guide your clinical judgment.
And to understand what is happening with that patient in room 4 and keep them safe, you first have to crack the code on the 3Ds.
The 3Ds, yeah, the NCLEX loves testing this. And confusing them in practice can be legitimately dangerous.
It really can. So let's break down those critical differences. First up, we have delirium.
Right, which is your acute medical emergency.
Exactly. Delirium is acute, it has a sudden onset, and the good news is it's usually temporary and reversible.
Because clinical experience shows it is almost always caused by an underlying physical issue.
Yeah, like a raging urinary tract infection or an electrolyte imbalance or maybe some medication toxicity.
And here is the crucial NCLEX point you have to remember. Delirium alters the level of consciousness, the LOC.
Right. The reticular activating system in their brainstem, which is basically the power dial for wakefulness, is just malfunctioning.
So they might be, practically comatose 1 hour, and then hyper alert and combative the next.
Now, dementia, on the other hand, is completely different.
Right. It's chronic, gradual, and unfortunately irreversible.
Yeah, it's caused by neurodegenerative diseases. And the biggest difference, it does not alter the patient's level of consciousness until the very, very advanced stages.
So the power dial on the brainstem is fine. A patient with early dementia is fully awake and alert. It's their processing power that's compromised.
Exactly. And then you have the third D, which is depression.
Right, which in older adults can actually mimic dementia. Sometimes they call it pseudodementia.
Yeah, but depression is treatable, and it's characterized by mood changes that last more than 2 weeks.
Okay, so let me ask a practical bedside question here.
Sure, go ahead.
If a patient already has advanced dementia, how in the world do we know if they're experiencing delirium on top of it? What is the specific clinical clue?
That is such a good question. You have to look for an acute change from their known baseline.
An acute change. Okay.
Right. So if a normally agreeable dementia patient suddenly develops visual hallucinations, or if their level of consciousness starts rapidly fluctuating,
Then you have to suspect delirium.
yes, you suspect delirium and you start hunting for that underlying physical cause like a UTI.
That makes so much sense. But sometimes that sudden change in baseline isn't an infection.
Oh, absolutely.
Because people with structural brain damage, like advanced dementia, they are at a significantly higher risk for abnormal electrical activity in the brain.
Right, seizures. So imagine you walk into a room, the patient is profoundly confused, drowsy, agitated.
And then you notice they have been incontinent of urine, and maybe there's a small laceration on their tongue.
That combination of clues should immediately shift your clinical thinking. You're no longer just suspecting a UTI.
No, you are looking at the aftermath of an unwitnessed seizure. And this is why the postictal nursing assessment is so heavily emphasized on the NCLEX and in real practice.
Exactly. When a brain goes through a generalized seizure, it is like a city experiencing a massive electrical surge.
The neurons fire out of control, right?
Yeah, and it rapidly depletes the brain's stores of glucose and ATP, which are its core energy sources.
So the postictal phase is basically the brain rebooting after a massive power failure.
Exactly. The cells are exhausted. That is why the patient is so drowsy or confused or even combative.
So your immediate nursing priority always is airway and breathing. You check their oxygen saturation.
Right, because the airway might have been compromised during the seizure. You also have to check their level of consciousness, orientation, and do a full neurocheck.
And check for injuries. Did they hit their head? Did they bite their tongue?
Yes. And here is a huge rule. Do not leave the patient alone immediately after.
Never. They are so vulnerable.
Their swallow reflex might be sluggish, so they are a massive aspiration risk. Plus, the confusion makes them a huge fall risk.
And your documentation here has to be flawless. You don't just write, patient had a seizure.
No, you have to document the exact start and stop time, the movements, the body parts involved.
An eye deviation. That's a big one.
Oh, massive clue. Because eye deviation often points to the hemisphere of the brain where the electrical storm started.
Right. And you document loss of consciousness, triggers, meds given, and their exact postictal behavior.
Yeah, how long it took them to recover tells the medical team how severely the brain's energy was depleted.
So understanding that kind of metabolic exhaustion really brings us back to the structural damage of dementia.
It does, because to understand what's happening at the bedside, we have to look inside the most common type, Alzheimer's.
Right. The actual broken machinery of the brain. The neurons are basically fighting a two-front war.
Exactly. So on the outside of the neurons, you have beta amyloid plaques building up.
And these plaques basically block communication, right? Like physical roadblocks between the cells.
Yes, exactly. And meanwhile, on the inside of the neurons, you have neurofibrillary tangles building up.
Made of tau proteins, right?
Yep. And these tangles literally destroy the internal structure of the cell. The cell starves and dies.
Which leads to actual brain atrophy. The tissue literally shrinks.
It's devastating. And that physical shrinkage explains the highly tested NCLEX terms you'll see, the 3 A's.
Ah, yes. Apraxia, aphasia, and agnosia. Let's translate those into plain English.
So apraxia is the inability to perform motor movements.
Right, like they have the muscle strings, but they can't coordinate the steps to, say, brush their teeth.
Exactly. Then there's aphasia, which is the inability to understand or create speech.
And finally, agnosia, which is when they can't recognize familiar objects or people.
Like handing them a fork and they try to comb their hair with it. The visual input works, but the meaning is just erased.
So families always ask about medications here. Donepezil or memantine.
Right. Donepezil is a cholinesterase inhibitor and memantine is an NMDA antagonist.
But the crucial point to emphasize is that these do not cure the disease.
No, they don't. They only slightly improve cognition or, slow the progression a bit. They don't fix the structural damage.
It's kind of like, think of trying to help someone hear music through broken headphones.
Oh, that's a great analogy.
Right, like the hardware itself is broken, so turning up the volume on the phone or just using more logic is never going to fix the connection.
Exactly. The frontal lobe, which handles logic and reasoning and impulse control, is damaged.
So arguing with the patient or trying to correct their reality, it doesn't work.
It just causes anxiety, shame, and defensiveness. We have a great bedside rule for this.
Yeah. Oh, I love this rule. Connection regulates behavior. Correction escalates it.
Yes. Because their logic center is compromised, our nursing interventions have to adapt entirely to their reality.
We can't ask them to step into our world. We have to step into theirs.
So let's talk communication. First rule. Never tell a dementia patient to calm down.
Never. It just triggers a fight or flight response.
And avoid asking open-ended questions like, don't ask, what do you want to wear today?
Right, because that causes overwhelming decision fatigue for a damaged frontal lobe.
Instead, you use forced binary choices. You say, do you want the red shirt or the white shirt?
It's so much easier for them to process,
Yeah.
and we have to adapt the physical environment the same way.
Yeah, clinical experience shows we have to minimize noise, turn off the TV, clear the clutter. It prevents cognitive overload.
And speaking of the environment, safety is huge. The NCLEX loves testing this one. Remove scatter rugs.
Yes, scatter rugs are major trip hazards because of changes in their gait and depth perception.
You also want to keep the rooms well lit and place door locks out of their direct line of sight to prevent wandering.
Right, put the locks really high up or really low down.
And then there's sundowning. That period in the late afternoon where confusion just spikes.
Yeah. As the brain declines, its grip on the sleep-wake cycle fails. So to address sundowning, we limit late naps and we cut out afternoon caffeine.
Okay, let's talk nutrition, because that's a big struggle at the bedside.
It really is.
Mhm.
As the disease progresses, they lose the ability to use utensils.
So a highly tested intervention is offering finger foods, things they can carry with them if they're wandering.
Exactly. And minimize distractions during meal times. You'll also notice they gravitate towards sweets.
Oh, yeah. Why is that?
Well, other taste buds diminish, but the receptors for sweetness are tied to primitive survival mechanisms, so they survive the longest.
That makes total sense.
Yeah.
Now, let me ask you another practical question.
Go for it.
It is so tempting as a nurse to just gently remind them of the truth when they say something incorrect. Like if they ask for their husband who passed away years ago, what is the actual harm in just kindly correcting their reality?
Oh, the harm is massive because forcing them to reconcile a reality their brain can no longer process triggers a massive fight, flight, or freeze response.
You're essentially making them relive the raw grief of that loss all over again.
Exactly. We must validate the emotion behind their words rather than the factual accuracy of their statements.
So you say something like, "You must really miss him, tell me about him."
Yes. You redirect to a safe emotional memory.
Now, as we manage all these daily interventions, we also have a massive responsibility to assist the family.
We do. Especially as the disease progresses to the final terminal stages, we have to help them with care planning.
Because the progression of dementia isn't just a straight ski slope down. It's more like a stairway.
Right. They decline, they plateau, then they drop sharply from an infection like a UTI, and they bounce back slightly but never to their old baseline.
And then they plateau again. It makes it incredibly hard for families to know when the end is near.
It really does. So we teach them to recognize end-stage signs using a simple formula. Can't walk, can't talk, can't eat.
When you hit that point, we have to talk about the vital role of hospice and palliative care.
Yeah, the focus shifts entirely to comfort. We want to avoid hospitalizations.
We manage pain, thirst, and agitation, but without over-medicating them into a stupor.
And we have to address feeding, because around 42% of advanced patients actually forget how to swallow.
The neurological sequence just breaks down, and that leads to aspiration pneumonia, which is the leading cause of death.
Which is exactly why we must emphasize to families that we do not force feed.
But man, that is a hard conversation. How do we help family members who feel immense guilt about not forcing their loved one to eat at the end of life?
It's one of the hardest parts of nursing. But explaining the natural dying process is a core nursing duty.
You have to assure them that losing the drive to eat is a natural, expected part of the neurological shutdown.
Right. The body is redirecting all its remaining energy. Force feeding actually causes harm and suffering via aspiration.
You just have to let the body be the guide and give the family other ways to show love, like mouth care or holding their hand.
Exactly. Okay, let's briefly recap the most important lessons we covered today.
First, we distinguished the 3Ds, dementia, delirium, and depression, and how to spot the acute emergency of delirium.
We also covered the postictal seizure assessment. Check airway, breathing, injuries, and never leave them alone.
Then we talked about how physical brain damage, the plaques and tangles, means logic no longer works.
Right, which means we have to utilize practical bedside interventions. Binary choices, removing scatter rugs, and offering finger foods.
And finally, guiding families through the emotional shift to palliative care and understanding the loss of the swallow reflex.
Our goal is for you to walk away from this feeling like, okay, this matters, but it actually makes sense now.
Yeah, and I can use it at the bedside.
Exactly. If this helped you, please go watch the video on YouTube, like, subscribe, and leave a comment.
And don't forget to visit supernurse.ai for great resources helping you become the super nurse you were born to be.
Before we wrap up, I want to leave you with one final provocative thought about your own nervous system.
Oh, this is important.
Because dementia patients lose the ability to decode language, they become hypersensitive to your tone and your body language.
You read your energy because they can't read your words.
Right. So consider that when a patient is entirely dysregulated, your own calm, regulated nervous system might be the most powerful, immediate medicine you can provide in that room.
Co-regulation. It is so powerful. Thank you so much for joining us, and we'll see you on the next one.